Good afternoon, everyone. I'm going to go ahead and get started. Welcome to the University of New Mexico Department of Psychiatry and Behavioral Health Grand Rounds. My name is Dr. Marquette Rose. I'm the Reproductive Psychiatry Fellowship Director. It is with great excitement that I get to introduce our current Reproductive Psychiatry Fellow, Dr. Dominique Price, who will be presenting on Reproductive Psychiatry Reimagined, Exploring Mental Health Across the Lifespan. Dr. Dominique Price earned both her Ph.D. in Biomedical Sciences and her M.D. from the University of New Mexico, where her early research focused on infectious disease, vaccines, and immunology. During medical school, she developed a strong interest in psychiatry and was honored with induction into the Gold Humanism Honor Society and the Leonard Tow Humanism in Medicine Award. She completed her general psychiatry residency at UNM, where she cultivated a passion for reproductive psychiatry and received the Rosenbaum Research Award for her proposed work on inflammation and premenstrual dysphoric disorder. She is currently completing a fellowship in reproductive psychiatry. Dr. Price is committed to advancing the field through a career in academic medicine, integrating clinical care, research, and teaching to improve outcomes for patients during reproductive transitions. Thank you so much, Dr. Price, for sharing your expertise with us today. I'll go ahead and pass it to you.
Thanks so much, Dr. Rose. Okay, I'm about to share. All right. Good morning, everybody. Thank you so much for being here. Today, we're going to reimagine how we think about psychiatry. We're going to think about it not as just a brain-based discipline, and I know many of us don't think of it as something that just the brain controls. But I want us to lean into thinking about psychiatry as something that's deeply connected to the body, and in particular to the reproductive life cycle. From puberty to pregnancy to menopause, hormonal transitions profoundly shape our mental health. Yet reproductive history is often overlooked in our psychiatric evaluations. Our goal today is to explore how we can integrate a reproductive history into our psychiatric histories, how we can understand disorders like PMDD more precisely, and how we can better support patients through menopausal transitions, truly practicing psychiatry across the lifespan. I don't have any financial interest to disclose, and I have no other conflicts of interest to disclose. So our objectives today, by the end of this talk, we should all be able to describe the importance of taking a reproductive history and assessing hormonal factors that may be contributing to mental illness. We should be able to recognize premenstrual dysphoric disorder and differentiate it from other mood disorders. And we should be able to compare and contrast pre, peri, and postmenopausal depression and also some other psychiatric illnesses that can become exacerbated during this time. I know we have residents in the audience, and so I've included some vignettes as well as some practice questions, as I know that both PMDD and menopausal mental illness are not often covered in our classic training, and we are tested on them in boards, so they're in the board style. So I want us to go forward and think about reproductive transitions as periods of risk. We're not going to talk about pregnancy and postpartum today. Those have been talked about previously by some of my wonderful colleagues. And instead, we're going to focus on reproductive cycles and menopause. The other thing I want to say is that going forward, I'm going to usually use the word women because much of the research investigating reproductive health describes individuals who identify as women. But in actuality, we know that this is a much larger group that encompasses anyone with ovaries and a uterus, so much larger than just cis women. And we should also be thinking about these transitions with our intersex patients, patients who are trans, as well as people who are non-binary. And so there's a lot of data to suggest that any person with ovaries is at risk. And when we study these other populations, we actually know that circumstantial contexts may actually worsen their illness. I want to start with a story. A 32-year-old woman, Maria, came into a clinic and she came in for what had been described as chronic depression. She'd been on and off several SSRIs since college. And when I asked about timing, she mentioned that her mood would absolutely plummet the week before her period. She'd cry easily, she'd feel hopeless. Sometimes she'd even have suicidal thoughts, which was completely out of the norm for her. But within a few days of menstruation, she'd feel completely fine. No one had ever asked about the timing of her symptoms before, and when we tracked her mood across 2 cycles, it became clear that she met criteria for PMDD. Treating her cyclically and validating that this was hormonally driven transformed her functioning and her sense of control. I want to share some statistics with you. So the first statistic is listed here on the slide, and that's a retrospective chart review found that fewer than 10% of any encounter documented contraceptive status, despite over a third of patients having a documented prior pregnancy. Additionally, a nationwide patient survey indicated that mental health problems influenced reproductive decision-making in at least 1/4 of our patients. And a survey conducted by a national mental health panel found that patients with mental health problems reported significant challenges in reproductive health and family planning, indicating a strong need for discussions about reproductive health. Historically, psychiatry has viewed hormones as peripheral, something for our wonderful OB/GYN colleagues to manage. But now we understand that fluctuations in estrogen and progesterone profoundly affect serotonin, dopamine, GABA, neurotransmitter systems directly tied to mood and anxiety. And modern research that's ongoing continues to underscore that these hormonal shifts aren't just triggers, but they're key biological mechanisms that shape vulnerability and resilience throughout women's lives. And so the field of reproductive psychiatry is reframing how we think about mental illness in terms of thinking about it across different life stages: the menstrual cycle, pregnancy and postpartum, perimenopause, and menopause. Each phase involves biological changes, hormones, neuroendocrine shifts, but also psychosocial changes, identity, body image, fertility, and then social context, partnering, caregiving, getting older. And so this framework that I'm thinking about integrates biology, psychology, and social factors, offering a more holistic and person-centered approach to mental health. It also helps residents recognize patterns: cyclic mood worsening, postpartum onset, perimenopausal anxiety, and these inform our diagnosis and treatment. So as I mentioned earlier, typical psychiatric intakes often ask about mood, sleep, trauma, family history, but we're not always trained to ask about menstrual patterns, contraceptive use, fertility treatments, pregnancy, menopause. And as a result, hormone-related psychiatric symptoms can be misdiagnosed as major depressive disorder, generalized anxiety disorder, bipolar spectrum. And so not asking these questions can lead to unnecessary polypharmacy and missed opportunities for targeted interventions. I show here 2 pictures to sort of underscore this point. Depakote is a common mood stabilizer, and it can have, as we all know, serious reproductive consequences, both for men and women. And so if we're not asking about a patient's reproductive future or their goals, we may prescribe a medication that could have some very serious consequences. And so just again, we need to be asking not just about current fertility, but also future plans of fertility. So after hearing Maria's story earlier, my question becomes, how could we have recognized this sooner? And I think the answer lies in taking a structured reproductive history. And so again, in a standard psychiatric intake, most of us were never trained to ask detailed questions about menstrual patterns, pregnancy history, menopause. Yet I'm telling you right now that these factors dramatically influence the diagnosis as well as treatment response. And so we should be asking about the menstrual cycle and hormonal fluctuations. Do you notice mood or anxiety changes across your menstrual cycle? We should ask about contraceptive use and response. Specifically, have you noticed that your mood changes when you're on, combined oral contraceptives or progesterone only methods? We should always note a patient's pregnancy, postpartum, or lactation history, fertility treatments, and reproductive loss. We should always be asking gently about infertility, IVF, miscarriages, stillbirths. These are strongly associated with depression and anxiety. We should be asking about perimenopause and menopause and symptoms that they may be having, and then hormone therapy and endocrine disorders, because we know things like PCOS, and then something we already asked about, thyroid disease, can really mimic or exacerbate mood symptoms. And so for residents, I want you to think of menstrual. So this is an acronym that helps me remember. So menarche, endocrine, nausea/PMS, symptoms cyclical, transitions, reproductive history. It's infertility, but you can think of it as unfertility, anti-conception, and life stage. And so what I hope is that we start to think about a reproductive history, not just telling us about biology, but giving us a context of a patient's lived experience, transitions, and vulnerabilities. And so we're going to start with a case, the case of recurrent depression that wasn't. A 32-year-old woman, Lauren, presented with what had been labeled as recurrent major depression. She described episodes of severe irritability, hopelessness, emotional lability. She'd been started on 3 different antidepressants over the years, each of which would work for a little while and then stop. And when asked about timing, she reported frequent lows, moodiness, without a clear seasonal or psychosocial trigger. A few months earlier, she had stopped her oral contraceptive pills while trying to conceive, and her mood symptoms became significantly worse. She was encouraged to track her symptoms prospectively across 2 cycles and confirmed a clear luteal phase pattern consistent with premenstrual dysphoric disorder. Once diagnosed, she was treated with a serotonergic antidepressant dosed just during the luteal phase and offered psychoeducation and lifestyle adjustments. And within 2 months, she described the treatment as life-changing. So Lauren's case isn't rare, it's just rarely recognized. So I want to spend some time looking a little more closely at PMDD and how it differs from other mood disorders, and why understanding the menstrual cycle is key to an accurate diagnosis. So the average woman experiences approximately 480 total menstrual cycles in their lifetime. Pictured here in the salmon-colored box, we see that the average women's menstrual cycle. And so notably, day 0 to 14 is the follicular phase. And it includes the start of menstruation to ovulation. And during this phase, estrogen is the predominant hormone. At day 14, there's a spike in luteinizing hormone, and this triggers ovulation. And from ovulation to just before menstruation is the luteal phase. And here, progesterone becomes the predominant circulating hormone. And so it's this luteal phase of the menstrual cycle where women with premenstrual disorders experience physical or emotional distress. And 90 to 95% of women will report experiencing at least one undesirable premenstrual physical or emotional symptom. And they can range from mild to severe. And I like to think of them in 3 different types. So the first is PMS. And so PMS is a pattern of physical and emotional symptoms that occur 5 days prior to menses, and then they resolve with menstruation. And it's estimated in terms of prevalence that about 20 to 30% of women have a diagnosis of PMS. When we look at meta-analyses, this number is actually much higher and closer to 50%. The second premenstrual disorder that I want to tell you about occurs in women who already have psychiatric illness. Um, and so what they see is premenstrual exacerbation of their underlying illness during the luteal phase of their cycle. And it's estimated that 50% of women with mood disorders have premenstrual worsening of their symptoms during the premenstrual part of their cycle. And then third and finally, a much smaller minority of women meet criteria for premenstrual dysphoric disorder. And so PMDD joined the DSM in 2013. It was previously known as mood disorder not otherwise specified, and prior to that as late luteal phase dysphoric disorder. And it's estimated that 1.3 to 7% of women have PMDD. And so I think it's really important to understand the subtle differences between PMS, PMDD, and PME. And so for PMS, what we see here is that you can see it requires at least one symptom from either the pinkish box or the white box before the period. And then it has to be present for at least 3 menstrual cycles. And then the other criteria is that it end within 4 days after the period starts. And usually PMS interferes mildly with some normal activities. We're much more strict in the DSM about the criteria for PMDD. And so with PMDD, we need at least one core symptom. And you'll see in the purple box that core symptoms include marked affective lability, marked anxiety, marked depression, and persistent irritability. And then they need to have at least 5 total symptoms present for most of the week during that second week of the luteal phase, just before menses. And then all of those symptoms should remit or mostly remit a few days after menses. Now, the difference between PMS, another difference is that people generally will see marked disturbance in their usual activities. Women will say that it affects their productivity. Sometimes they can't go to work, and it greatly affects their interpersonal relationships. And then lastly, there's premenstrual mood exacerbation. And so again, this is exacerbation of an existing affective illness premenstrually. It's not noted, it's not a diagnosis in the DSM. And in general, we think that the agreed upon change among experts is 30 to 50% marked exacerbation of symptoms during that premenstrual part of the cycle. And so ultimately, the difference between all of these, it lies in severity, duration, and functional interference. And so the pathophysiology of PMDD remains unclear. There are multiple proposed biological mechanisms to explain the pathophysiology. So the thing that is most agreed upon is that research has shown that women with premenstrual disorders have altered sensitivity to normal hormonal fluctuations, specifically estrogen and progesterone. Hormonal fluctuation is really the key component of pathogenesis, and we know this because symptoms don't appear before menarche, they don't appear during pregnancy or after menopause. We're going to talk about how menopause is different, but they should remit during that phase. Interestingly, when we study women with premenstrual disorders, they don't differ from asymptomatic women in terms of peripheral ovarian hormone levels. And so when you're thinking about PMDD for some of our patients, we don't need to get hormone levels to make this diagnosis. So when we look at like biological risk factors for PMDD, we know that premenstrual disorders appear to have a heritable component. And implicated genes include brain-derived neurotropic factor, estrogen receptors 1 and 2, and then the serotonin transporter. And then looking at etiology kind of in a broader sense, I've listed some mechanisms of pathology on the left. And so it's important to say that none of these theories negates the other, and that they may all be true. But at the top is probably the most agreed upon um, theory right now, which is that either withdrawal from or exposure to a progesterone metabolite, allopregnanolone, which is a GABA A receptor modulator, causes pathology. Another theory is that uh, somehow the estrogen may modulate serotonin and play a role in some of the mood effects. And then the last theory is that immune activation and inflammation may be associated with worsening symptoms in these women. And so I think it's interesting to kind of bring the third point back to the first, which is that allopregnanolone actually has a lot of downstream immune consequences. And so, again, they may all be true. And so highlighted in the dark green box, again, it's not hormone levels, but it's response to fluctuations in hormones. Treatment for PMDD remains an area of active research. In the clinic, we should always be thinking about SSRIs first. Sertraline, fluoxetine, paroxetine, escitalopram, and citalopram have all specifically been studied for PMDD and are equally effective. What's very cool, I think, is that we can use intermittent dosing of SSRIs 2 weeks prior to menses during that luteal phase. And it's been shown to improve mood in PMDD patients. And we think it's because of the decrease in serotonergic function during that luteal phase. What's also very cool, because you may be thinking, well, what about discontinuation syndrome? Um, we know that luteal phase dosing is as effective, and there is no withdrawal phenomenon that has been notable in research when we study just luteal phase dosing. I should also say that SNRIs have been studied, specifically venlafaxine and duloxetine. But it's important to note that there's very limited data on intermittent dosing with SNRIs. Going down our algorithm, in 2006, the FDA approved an oral contraceptive pill containing drospirenone for the treatment of PMDD. And drospirenone is a synthetic progesterone that's derived from spironolactone. And they did this because other synthetic progesterone OCPs were associated with mood symptoms. And spironolactone demonstrates efficacy in treating PMDD, less mood side effects, and also has the added benefit of improving women's physical symptoms as well. Gonadotropin releasing agonists have also been studied more in refractory PMDD. And they've been shown also to be effective, more effective than placebo in reducing PMDD symptoms. However, it's always important to talk with your patients about the side effect of hypoestrogenism and that they may experience hot flashes or night sweats, as well as be at risk for decreased bone mineral density. I included CBT on this list a little lower, and that's because while I think that psychotherapy could potentially be useful throughout PMDD treatment, I included it lower on the list of evidence-based treatments to suggest or to describe some research that's shown it for refractory PMDD symptoms, with the treatment really reflecting what we do with CMBD sorry, with PMD, I'm so sorry. So it's to say that patients with refractory PMDD may benefit from CBT in a way similar to patients with chronic pain, in the sense that they are sort of learning to manage something that has not responded to treatments. And then the last treatment I show here is a neurosteroid modulator, specifically spranolone, which is currently still in development and research phases. But this agent targets the GABA receptor and modulates the effects of allopregnanolone in the CNS. And so a 2017 study showed some really incredible results in terms of treating PMDD. I will just say that it was notable also that these studies showed a pretty high placebo effect. And so I think there's more research to be done here. Not shown here, last resort in our algorithm is surgery, which is considered a last line of treatment for women. And what's really interesting is when women with refractory PMDD have an oophorectomy and hysterectomy, estrogen replacement often causes symptoms to recur. And so that's not always an option for patients. Okay, so we're going to practice some questions. So a 32-year-old woman reports worsening mood and irritability in the week before her menses that resolves within a few days after onset of menstruation. She has no mood symptoms for the rest of her cycle. Which feature most clearly differentiates PMDD from premenstrual mood exacerbation of major depressive disorder? A, greater severity of mood symptoms during the luteal phase. B, response to SSRIs. C, complete symptom remission during the follicular phase. Or D, association with hormonal contraceptive use. And so I hope that you answered C, because in PMDD, there is a complete or near complete symptom remission during the follicular phase of the cycle. With PME, we would expect symptoms not to fully remit, but only get a little bit better. Which of the following best explains the neurobiological mechanism underlying PMDD? A, decreased estrogen and progesterone levels in the luteal phase. B, abnormal sensitivity to the GABA A receptor modulation by allopregnanolone. C, reduced serotonin synthesis due to low tryptophan. D, elevated cortisol leading to HPA axis dysregulation. And so again, I hope you were like, oh, I remember Dr. Price mentioning allopregnanolone several times. And so we know that women with PMDD have normal hormone levels, but the fluctuation of hormones, particularly estrogen, progesterone, and allopregnanolone, seem to cause pathology. Last question for this part of our talk. A patient with prospectively confirmed PMDD prefers not to take daily medication. Which of the following options best aligns with evidence-based treatment of her condition? A, sertraline, 50 milligrams, titrated as tolerated. B, 50 milligrams, but only during the luteal phase. C, bupropion, 150 milligrams daily. Or D, combined oral contraceptives. And so I hope that you notice that she says she prefers not to take a daily medication. And so we can consider intermittent dosing just during the luteal phase. So this distinction between PMDD and premenstrual mood exacerbation is not just academic. My research sheds light on how we can refine modulators of PMDD as well as treatment. And so we are looking to investigate the question, are inflammatory status and inflammatory fluctuations across the menstrual cycle associated with mood severity? We enrolled 24 reproductive age women. We're still enrolling, so if you would refer any potential participants to it, we would love that. So our three groups are women with PMDD, women without PMDD, they can have PMS, and then women with mood disorder with premenstrual exacerbation. So very briefly, just describing our patients or our participants thus far. They've had a large age range. All of them had a normal menarche. There was, again, a wide age range of when they'd received their PMDD diagnosis, if they had a PMDD diagnosis. All of the participants thus far have had an additional psychiatric diagnosis. The most common is PTSD. Second most common is generalized anxiety disorder. All of them, almost all of them, have had children and have described worsening of their symptoms after children. And then a potential flaw thus far in the study, because it introduces bias, is that all of our patients have had college or higher degrees. And so we would like more variety there to sort of reflect the population. And so when we look at the study design, we're having women monitor and score their symptoms, their mood symptoms and physical symptoms throughout their cycle. And so you'll see here there are 2 cycles listed. And so in their monitoring of their symptoms throughout that first cycle, they're also categorizing their cycle in terms of sort of when we can expect menstruation. And so in the second cycle, we're still asking them to report their symptoms, but now we can try and predict when they're in the follicular phase and when they're in the luteal phase. And we can do a blood draw for a common inflammatory agent in the blood, C-reactive protein. And we can see if it changes across the cycle. And so that's the data that I'm going to share with you right here. So this is change in symptom severity and inflammation across the cycle in our study. On the right graph, you'll see this is specifically change in symptom severity scoring. And the y-axis is labeled average difference between follicular and luteal symptom severity. In blue are women with PMDD, and in orange, these are women with PME, or premenstrual mood exacerbation. And what we see is that on average, women with PMDD have a greater swing in terms of the severity of their symptoms, which we would expect, right? They go from 0 to, or they shouldn't have any symptoms during the follicular phase, and then they have severe symptoms during the luteal phase. On the right, we see temporal change in CRP, our marker of inflammation. And so the y-axis here says average difference between follicular and luteal CRP. Again, in blue is PMDD, and in orange we have our PME. And what we see is that they're actually quite different. And so the women with PMDD do have a greater change in inflammatory status across their cycle, which may mean that we can potentially down the line think of treatments that may help. We're going to switch gears a little bit, and we're going to focus on a new case, the case of new onset later life depression. So Angela, a 47-year-old teacher, came to the clinic describing irritability, fatigue, a sudden anxiety that she'd never experienced before. She said, "I feel like I'm losing my mind. One week I'm fine, and the next I'm crying in my car before work." Her cycles had been irregular over the past year, and no one had connected them to her mood. She'd been started on bupropion and then escitalopram, neither which offered any benefit. When we reviewed her history in detail, it became clear her mood symptoms worsened with skipped cycles and around hot flashes, which is classic for perimenopausal mood instability. Hormone therapy plus a low-dose SSRI stabilized her mood and improved her sleep within weeks. So beyond the reproductive years, mental health remains hormonally receptive and sensitive, especially during the menopausal transition. Like premenstrual disease, perimenopausal and menopausal disease is largely understudied. And so much of the information that I'm going to share with you today comes from 3 prospective cohort studies. the study of women's health across the nation, the Penn Ovarian Aging Study, and the Seattle Midlife Women's Health Study. What does appear to be very clear is that perimenopausal women experienced depressive symptoms at much higher rates than premenopausal women. So let's dive into that a little more closely. So menopause is defined as is defined by declining reproductive hormone levels, most commonly estrogen. It's understood again that hormonal fluctuations during the reproductive period are associated with mental illness. We just talked about that with PMDD. And so it makes sense then that at this menopausal transition, where there is a huge fluctuation in hormones, we again see increased risk for mental illness. Once again, estrogen and progesterone fluctuations have been shown to affect serotonin and other neuronal networks that regulate mood. Um, yeah. Among women with no history of depression, depressive symptoms are 4 times more likely when a woman is in the menopausal transition compared to the premenopausal state. And an actual diagnosis of major depressive disorder is twice as likely in a woman who's going through perimenopause versus a woman who is going through or who is still premenopausal. The odds of experiencing a depressive episode during the menopausal transition is 3 times more likely among women who already have a history of major depressive disorder. And so, um, notably, a long history of depression and other risks have been identified as sort of contributing to this risk. So the later that you go through your menopausal transition, vasomotor symptoms, current life stressors, psychosocial difficulties, all of these may play into the severity of the mood episode that we see during this time, again, sort of grounding us in that biopsychosocial model of evaluating our patients. And so when I'm assessing a patient for perimenopausal or menopausal depression, I'm sort of walking through the biopsychosocial um, perspective. So biologically, like have they missed, how many cycles have they missed? What could be being affected? And then psychologically, have there been identity shifts, motherhood, aging, body image as we get older? Socially, like, are you a caregiver? Are you dealing with some role transitions? Do you have access to care? This integrative lens helps me avoid over pathologizing a normal transition, but ensures I don't miss a treatable disorder. And so I know that this slide is a lot, but we are going to walk through it. So we met Angela earlier, the 47-year-old teacher who thought she was losing her mind during perimenopause. Her story captures what a lot of women experience, which is unpredictable mood swings, anxiety, and irritability emerging as part of these hormone pattern shifts. And so typically women undergo perimenopause around the mid to late 30s. And so you'll see that first pane in the slide shows late reproductive phase. And so women might start to notice like that their cycle may be a couple days short or a couple days longer. But when the cycle length starts to vary by more than 7 days, we think a woman may be in early perimenopause. And then as we move into late perimenopause, this is when we start to miss more than one cycle, maybe 1 or 2 months. And we will also start to experience some of the classic perimenopausal physical symptoms. So irregular cycles, I just mentioned, but vasomotor symptoms, sleep concerns, sexual problems, and many women will report cognitive concerns. They're worried they're developing a dementia of some kind. As we move forward, early menopause is defined as 12 months without a period, and as we move into a late menopause, we can sort of potentially predict persistent low mood and sleep issues. And so I talked a lot initially about depression, but I think it's important to talk about um, other exacerbations of mental illness during menopause. So in our training, I learned, and I'm sure many of us learned, that bipolar disorder has this bimodal distribution in women, with an onset during early adulthood, but also during later years, ages 45 to 54. However, the association between perimenopause and first onset bipolar disorder remains an active area of study, with only a few studies actually demonstrating a possible association. So evidence remains low. But again, these are women who have no previous diagnosed mood disorder. However, in contrast to that, women who already have a diagnosis of bipolar 1 and 2, we know that they are at increased risk for a depressive episode during perimenopause. And some smaller studies have actually shown that women with bipolar illness scored higher on scales of both depression and mania symptoms during late perimenopause and early menopause, which may align with some of the sleep changes that we see around that time. With schizophrenia, there are, again, several studies to suggest that perimenopause is a time of increased risk for our patients with schizophrenia. Further, I think there is a fair amount of studies that show that HRT may improve symptoms of schizophrenia in women that are going through perimenopause. And this may be because some of our antipsychotics are less effective for women as time elapses in menopause, potentially because of estrogen's involvement in uh, the metabolism of antipsychotics. And then lastly, anxiety disorders. They're less well studied during the menopausal transition, but there is evidence of increased anxiety symptoms during perimenopause, even among women who have like low baseline anxiety before they transition. And so there appears also to be this very strong relationship between vasomotor symptoms and anxiety and panic. And so why? um, so the estrogen withdrawal and fluctuation hypothesis is probably the most prominent in the literature. We know that estrogen modulates serotonin, dopamine, GABA pathways, um, and that when it decreases, it destabilizes these mood regulation circuits. Again, the progesterone metabolite allopregnanolone, also we know it affects the GABA A receptor activity, also the HPA axis. And so similar neurobiology to PMDD, just a different hormonal context. We also know that some women have heightened CNS sensitivity to these fluctuations. We can think of them kind of as a hormonally sensitive phenotype. Um, and then we know that the vasomotor and sleep disruption that can happen during perimenopause can drive mood symptoms via the circadian and thermoregulatory mechanisms in the body. In the left, this is a picture that sort of describes pathology from a functional neuroanatomy perspective. And so I just want to spend a minute or two on that as well. So the menopausal transition may alter activity in the ventral limbic regions of the brain, including the medial temporal lobe, um, which is where we, consolidate negative emotional information. And so we think that this is potentially related to estrogen receptors, sort of their presence throughout that region of the brain. And then within the medial temporal lobe, estrogen has been linked to brain-derived neurotropic factor that's expressed in the hippocampus. And then lastly, MAOs, so not our inhibitors, but the enzyme that metabolizes serotonin and dopamine and norepinephrine. MAOA levels increase in the brain after decrease in estrogen. Which is seen significantly in perimenopause. And so when we look for MAOA levels in the brain of premenopausal women, perimenopausal women, and menopausal women, we know that perimenopausal women um, uh, have increased MAOs by almost 34%, and menopausal women have MAO levels 16% higher than premenopausal women. And so this has implications for our treatments. So how do we manage it? Again, SSRIs and SNRIs are the first line. So they're effective both for depression and vasomotor symptoms. Specifically, venlafaxine, desvenlafaxine, and paroxetine seem to have the best evidence. We can also consider hormone therapy for some of our patients. And so this is a controversial topic. Some psychiatrists have, reproductive psychiatrists will actually prescribe HRT. If we're going to consider it, we should consider it within the first 10 years of onset of menopause because that's when it's most effective. And we will do transdermal estradiol and then cyclic progesterone to kind of protect against clots as well as uterine cancer. So, but it may, or it does show great promise in terms of working as an augmenter for treatment-resistant mood symptoms. Other things we can do, so we should always, think about CBT that's tailored to menopause, sleep optimization, exercise, mindfulness, psychoeducation about these hormonal changes. And so what I hope I am sort of leaving you with here is the clinical pearl that perimenopause and perimenopausal depression is treatable. We just have to recognize that a hormonal context is driving mood symptoms. So we're going to test ourselves again. A 48-year-old woman presents with new onset irritability, insomnia, and depressive symptoms. Her menses have become irregular over the past year. Which of the following features most strongly supports a diagnosis of perimenopausal depression rather than recurrent major depressive disorder? A strong family history of depression. B, worsening of mood during the winter months. C, a history of postpartum depression 20 years ago. D, depressive symptoms temporally linked to menstrual irregularity and vasomotor symptoms. So I think this is an easier question, but hopefully you thought it was answer D. And so again, we're matching mood symptoms to that hormonal transition. Little harder question. Which statement best describes the proposed neuroendocrine mechanism contributing to perimenopausal vulnerability to depression? A, absolute deficiency of estrogen leads to decreased dopamine activity. B, progesterone levels remain high and they suppress serotonergic tone. C, estrogen or erratic estrogen fluctuations alter serotonin and GABA neurotransmission in susceptible women. D, testosterone decline increases noradrenergic activity. And so I hope that you saw the word fluctuation and remembered that again, it's these fluctuations in hormones that seem to be affecting our neurocircuits. And so with that, we're coming to the end of our talk. I just want to summarize everything we've talked about today. So hormonal transitions influence neurobiology, emotion, and behavior. And when we think about psychiatric care, we really must include that reproductive history and the hormonal context in which our patient is visiting us at. There are distinct yet connected mood vulnerabilities throughout the reproductive cycle. So PMDD, postpartum, perimenopause, they're distinct, but they're all connected, right? It's always these hormonal fluctuations that are driving symptomatology. And when we think about treating our patients, we should always be thinking about the biopsychosocial model and using that to help us come up with a great treatment plan. And so you can always consult reproductive psychiatry. You could collaborate with your OB/GYN colleagues, endocrinology, but we have a duty to treat, educate, and advocate for our patients. So if you take nothing else away from today's talk, I hope you will take a reproductive history. Start by asking, simple questions about where someone's at in terms of their reproductive lifespan. I hope you'll recognize PMDD as a hormonally sensitive and distinct and treatable illness. And then I hope also that we can, going forward, can really compare and contrast menopausal mood disorders and think about this time period as a window of risk, but also resilience. And so with that, I want to acknowledge my reproductive fellowship mentors, Dr. Rose, Dr. Higgins, Dr. Crawford, and then my research mentors, Dr. Abbott, Dr. Higgins, and Dr. Crawford. The department in general has just been so supportive. Dr. Crisanti for her mentorship, and also the Rosenbaum Award for allowing me to do my study. And then my PhD advisor, Dr. Pavan Mutil, is in the Department of Pharmaceutical Sciences and remains an amazing mentor and guide, source of guidance. And then these are two groups that are helping me with my research. So with that, I'd like to open the floor for questions. And if I may and say a huge thank you. But I'd like to ask you a question to kind of generate some discussion. And my question would be, if you could add one new question to your psychiatric intake after today's talk, what would it be?
Well, I'll have a question.
Yeah, sure.
Can you hear me?
Yeah, yeah.
All right. Well, that was a wonderful presentation, Dr. Price. Thank you. I mean, I learned a lot, and I'm certainly gonna pay much more attention to asking questions about reproductive status and health and menstrual symptoms. But my question is about you mentioned that the most persuasive hypothesis at this time regarding PMDD, the pathophysiology of PMDD, is something related to the effects of alpregnananolone. Yeah.
Mhm.
And I was just wondering, you mentioned a study, a clinical trial that tested an agent that targets that. But besides that, is there any direct evidence, or what's your knowledge of the best evidence there is to support the allopregnanolone hypothesis for PMDD? What's the best evidence?
Yeah, so a great question. So the best evidence really, sorry, the best evidence is really when we study levels that seem to be fluctuating the most during these transition periods. And so allopregnanolone is probably one of the ones that we know has the most CNS effects because of the GABA A receptor. And then what we see is that that allopregnanolone seems to fluctuate more potentially than estrogen, but again, Dr. Basile, to your point, we don't know. And in fact, we don't even know if it's the withdrawal from or if it's increases in allopregnanolone that's driving pathology. What we do know is that when we use things like OCPs, specifically the spironolactone derived ones, we think that we see remission, at least somewhat. And so again, allopregnanolone by itself is just a metabolite of progesterone. So it's not that it is more helpful or it's not that it's driving things more than estrogen or progesterone.
But you can measure allopregnanolone in blood, and it's been measured, I assume.
Yes, and again, levels don't differ between asymptomatic women. There is something to suggest that something within the CNS seems to be more sensitive in these women to the fluctuations. So even asymptomatic women have these fluctuations in the hormones. We don't know why some women are more sensitive than others.
Okay, thanks.
Yeah. Dr. Rose.
Hi, Dr. Price. Great presentation. I had a comment and then a question. Thinking about implementing this kind of in our history taking, us residents kind of use the same dot phrase in PES and admissions and stuff for history. And it would be a really easy add to just update this dot phrase to include contraception, reproductive history for women. So we'll work on that.
Awesome.
And then my question for you, and I've had actually patients ask me this, and I don't know the answer, so curious if you do. I understand that PMDD is a different pathophysiology than MDD, but how do SSRIs treat PMDD in the luteal phase when, um, it takes so long for them to work in depression? And so it's always like, but these medicines take a while to work. So do we know why they're working potentially before they even reach steady state?
Yeah, that's such a great question. And so we think when we think about MDD, there was this whole like replacing serotonin theory a while back, and we know that that's not the case, right? Our medications, our SSRIs take longer to work than just um, the short amount of time that we know we're increasing serotonin levels. And so we know that there are downstream effects from our SSRIs, and so when we switch that and when we think about PMDD, what we know is that something about adding serotonergic tone back into the brains of these patients seems to relieve some of their symptoms. And again, when we study the genes associated with this, we know that the serotonin transporter is associated with PMDD. We think that potentially estrogen and progesterone are modulating serotonergic tone during those times. So, but to your point, it's really understudied, and Dr. Bussia's point as well. We so much of this we still don't know.
Dr. Price, well done.
Thank you.
Um, I I think your study is so cool, and I want you, if you could, tell us maybe what the next steps are in a developing program of research um, after this pilot that you're doing.
Uh, um, well, so we're hoping at some point that we can kind of become our own division like of reproductive psychiatry. But as a group, we are applying for a pilot grant in the spring to hopefully set us up as a registry to do some research on patients that we're already seeing and already using medications that don't have a ton of research. And so, yeah, that's one way we're actively writing grants. But the other thing is that I'm hoping to stay, and I'm hoping to write a K award, kind of um, furthering some of the research that I'm doing right now.
Thank you.
Yeah.
We'll be
I
cheering you on.
saw Dr. Olguin wrote, has zuranolone been studied for PMDD? It is being studied for PMDD, Dr. Olguin. So great question.
I think some of the caveats with that, though, is that you'd have to still withdraw the treatment. And so
Yep.
going back to your point about fluctuations in hormones really being the etiology of this, there's still question with that.
Yeah. And then Dr. Rose says, do IUDs work as well as OCPs for some patients? So if the IUD is preventing ovulation, and we know that they don't always, so many women will still experience a cycle on even with the Mirena. And so if it prevented a cycle, then absolutely it would help. We just know that that's not the case all the time. But we try it. It's on our algorithm for sure. Great question, Dr. Rose. Okay, I'm gonna jump off. Thank you all so much for coming.